to make a start, and this is just to welcome Dr. Mike Groszmann. As you've heard from, as you've seen from his details, he's been in other parts of the country before being at UCLH in recent years, and he's taken on a really central role in different aspects, but this has really been, as far as we can judge, an entirely new enterprise of taking on the whole burden of mental health for children and adolescents in the centre of London. And he's very kindly agreed to come and talk to us. He gave us, titles that I understood: chaos, collaboration, and so on. I'm not quite sure what CAMHS stands for, but I'm sure we're going to hear about that.
Yes, yes, indeed. Okay, so let me start by trying to get the technology to work for me, and let's go to the beginning. Here. And hopefully you'll be able to see my slides. So, well, thank you. First of all, thank you very much, David and Jewish Medical Association, for inviting me to come and talk to you and share something of my experience of working over the last very interesting and memorable sort of 4 months. So my name's Mike Groszmann. I'm a consultant child and adolescent psychiatrist. I work at University College Hospital usually, and I'm the clinical lead there for child and adolescent psychiatry, working in the paediatric department. And today I'm going to talk to you about 5 C's, COVID, CAMHS, Child and Adolescent Mental Health Service. So that's the acronym for what often child and adolescent psychiatry is sort of referred to, although of course it's more than psychiatry, and that would be psychology, psychotherapy, and so on. Crises, collaboration, and chaos, and really it's telling the story of our experience of working over the pandemic. So just a quick summary. I'm going to briefly go through the context of the work that I do. And the work I do is hospital-based child and adolescent psychiatry, what we often call paediatric liaison psychiatry, the liaison being with our fellow paediatricians, nursing staff, and so on. And we work a little bit differently to a community CAMHS, a community child and adolescent mental health service, where they're usually outpatient-based and dealing with primary mental health problems. I'm going to go on to talk about what the sector-wide reorganisation involved when COVID and lockdown kicked in, and following that, talk to you about some of the themes and patterns of presentations that we saw. And I'll illustrate this with 3 sort of memorable case presentations that we dealt with, and that I think sort of give a picture of the sorts of difficulties and cases we've seen, and also the sorts of difficulties that young people are experiencing over this time. Then I'll share with you some reflections of my own, really, and a little bit about some of the studies that are starting to emerge around kind of the impact on children and adolescents' mental health, and then we'll hopefully have time for questions and discussion. So just to sort of set the context, so these are the 5 hospitals in North Central London is the term within the strategic transformation plan. That's very much how hospitals and the sector are kind of coordinated. It's what the PCTs and prior to that, the sort of the health bodies were organised in that way, and more recently STPs. So North Central London has 5 hospitals with paediatric departments: North Middlesex, Barnet, the Royal Free in Hampstead, Whittington and over in Islington, near Highgate, and UCLH in Euston. And UCLH is where I work. There's some variability in kind of the levels of provision, particularly for child and adolescent mental health within these. So in general, these three hospitals in the south of the sector, so Whittington, Royal Free and UCLH, are relatively well equipped or well resourced in terms of child and adolescent mental health. Barnet, Royal Free, Barnet Hospital, less so, and North Middlesex really has very little, and are mostly looked after by the community CAMHS teams that in-reach to these hospitals, whereas the three hospitals in the south of North Central London, in more central London, have a sort of dedicated in-house provision. So just a quick word, here's UCLH where we work on a beautiful sunny day. Sometimes it's like that. So we're a team of child and adolescent psychiatrists. There's 2.4 consultants, so 2 full-time, 1 2 days a week. And we're part of a psychological medicine team that includes psychologists and child and adolescent psychotherapists. And the psychological medicine team is part of the Paediatric and Adolescent division. So we're colleagues with, share an office with, and are very much part of Paediatric. So we're integrated, and I'm very proud of that, actually, that we do see ourselves as an integral part of holistic paediatric care, looking after mind and body. And we work within UCLH. We work up on the 12th floor, somewhere around here, 11th and 12th floor for paediatrics. And UCLH, as I showed, part of North Central London. Okay, just a quick illustration of the sort of work that we do. So a big part of the work is working around mental health crisis, increasingly so. When I first joined about 8 years ago, I would say that it probably made up maybe half, possibly even 2/3 of the work. So these would be young people in crisis coming into usually A&E, occasionally coming into a clinic, and becoming clear that they're in crisis. Those young people might be experiencing suicidal feelings or thoughts or attempts. They might experience psychosis. They may be experiencing very severe anxiety or panic attacks. We also see social crises, so a breakdown in family relationship, usually leading to lots of distress and sometimes seeking help, sometimes aggression at home, and other types of behavioural disturbances. So that's the crisis work. And then another significant part, and the reason we're part of the paediatric department, is that we also work with psychopathology that we see in physical illness. So in no particular order, although diabetes, we have a specialist, a quaternary service in UCLH, so working with adolescents in particular with diabetes. So we might see young people with diabetes who are really struggling to manage their chronic illness, and struggling often in their relationships with their family, which plays out in anxiety and eating difficulties, sometimes mismanagement of their diabetes. So with that and other endocrine disorders, neurological disorders, particularly epilepsies, rheumatological disorders, so inflammatory disorders, and autoimmune diseases, which can have a neuropsychiatric sort of consequence. Gastroenterological difficulties, people with Crohn's disease or ulcerative colitis, really difficult chronic illness and has a significant impact on patients' mental health. Hematological problems, patients with delirium, so a sort of organic psychotic-like state in intensive care, experience of trauma, and that could be physical trauma, but also psychological trauma, and manifesting and requiring hospital. And we look after people who have pre-morbid mental health problems and then become physically unwell. So anything from somebody with, for example, an autism spectrum condition or a severe depression who require surgery or for whatever reason need to be in hospital, and we can look after them whilst they're in. I've put this as a separate body. It's a very interesting and complex area of work, but the medically unexplained group, for any general practitioners, neurologists, gastroenterologists, you'll be very familiar with this, and GPs, of course. Functional neurological disorders. We see a sort of syndrome of hypermobility, Ehlers-Danlos syndrome, as it often described, alongside very severe anxiety and often various medically unexplained difficulties. Also functional gastroenterological disorders, and slightly controversially, because there's a large lobby of patients and people who don't see chronic fatigue syndrome or ME as medically unexplained. It's just not being described physiologically, but this group also have significant psychological difficulties, and we'll work with them, working very much alongside mind and body. And then UCLH has it's a primary treatment centre for children, teenagers and young adults with cancer. So I do a lot of work with the cancer service, working with patients and their families around at the point of diagnosis, adjusting to their illness, struggling with mood and anxiety problems, neuropsychiatric symptoms from brain tumours or tumours affecting the nervous system, problems with adherence to cancer treatment and working through that, and then sadly sort of, end of treatment, a surprisingly difficult experience. So somebody who's gone through the ordeal of cancer, and actually ending treatment can often be a very difficult time in their cancer journey. The late effects, so post-treatment, and people are struggling with the kind of aftermath, and then sadly sometimes palliation and supporting people towards the end of their life. And then finally there's the non-clinical work, which I find particularly interesting. So I lead the medical school at UCL for Child and Adolescent Psychiatry teaching, providing supervision, consultation to staff, offering staff support, and we also run Schwartz rounds, which I don't have time to tell you about, but it's an excellent model for engaging in the kind of emotional and psychological social reality of clinical work. So that's, in a nutshell, my usual work. But all that changed when COVID hit. So, so to put it sort of, to summarise the changes, well, there was a massive sector-wide reorganisation that needed to be done in less than 3 weeks. Normally, everything within the NHS sort of trundles along at snail pace. And suddenly we were being tasked with having to completely reorganise the pathways, and with a very short time limit. So all of the 5 paediatric wards in the diagram I showed you before were closed. The reason being partly to allow those wards to be used for adults, with the expectation that all of that capacity would be needed, partly also to try and avoid and keep out children from hospitals, anticipating they would become sort of COVID hothouses. And so a decision was made to move all the paediatric wards to a children's hospital, and that was Great Ormond Street Hospital. So all of the paediatric wards were closed, and all patients who paediatric patients in the whole sector needed to be admitted to Great Ormond Street. And the Great Ormond Street wards, as I mentioned below, we were offered the private wing, the Octa Botna wing, very swanky, much nicer than many of the paediatric hospital wards that we were previously working on. But staffed largely or significantly by doctors from the various hospitals, nursing staff as well. So the sector kind of collaborated to provide that service. The emergency departments, in order to sort of maintain capacity for COVID and adults in particular, only 2 emergency departments were kept open initially. So North Middlesex and Whittington in the south, and there was diversion of paediatric patients to those. So young people needed to go to there in order to be seen and assessed. I mentioned about Great Ormond Street. The Child and Adolescent Mental Health Service that was offered and provided within paediatrics was provided primarily by University College Hospital, so my team, and we looked after and managed the wards. Initially, it was a general paediatric ward, and mental health admissions went there. And subsequently, there were enough numbers that we actually opened one of the wards, and it was a dedicated mental health ward. So nursed by both paediatric nurses, general paediatric nurses, as well as mental health nurses, and they were offered from the Mildred Creek unit, which is an inpatient psychiatric unit for young people that's within Great Ormond Street. So we also had some additional support from the Great Ormond Street Hospital psychiatrists, child and adolescent psychiatrists, and that was the setup. In the sector, there was also two kind of hospital diversion hubs, they called it. Again, one in the north of the sector, and that was located in Edgware Community Hospital, and one in the south. And these were hubs where young people who were seen in the emergency department, if they didn't have any medical needs, then they could be diverted to the hub where they could have mental health assessment away from the physical health environment, partly to reduce footfall coming in, and partly to protect patients from having to be in a kind of COVID hot area, as they called it. So as you can imagine, to try and put this all into place, to try and draw up, we had to draw up kind of pathways, clinical pathways, and organise in a very short period of time kind of rotas, reorganise on-call rotas, and put this all into place in a very short period, and trying to maintain a good service and safety at a really difficult time. So there were some successes and there were some difficulties. We start with the successes, of course. This is actually in the background. I hope you can see the text, but in the background, this is the roof, very modern and artistic roof garden at the top of Octave Botner Wing, where we were housed for those 3 or 4 months. Very picturesque and very fitting for the successes. So. So the main success was really that the 5 different hospitals previously offered a very different level of care and a very fragmented mental health provision. As well as 5 hospitals, there are also 5 different sort of mental health sectors: Barnet, Enfield, Haringey, Camden and Islington, and each worked very separately. And I think the biggest, and certainly for me the most sort of memorable success, was of being able to create in such a short period of time a really effective, well-coordinated, sector-wide crisis pathway for children and adolescents who are in mental health crisis. That's not been achieved before. There was relative equity, so young people would have a fairly equitable experience across the sector, and all the different teams were truly working together in a collaborative and largely effective way. And that meant that overall there was a very positive patient experience. I don't know if you have clinical experience or kind of through stories and personally kind of there is a real narrative about the inadequacy of CAMHS services, and unfortunately sometimes that's that's not an unfair sort of narrative. Really, it's very underfunded and there's lots of problems and insufficient services, and in particular often young people find when they're in crisis that they have a difficult experience of it. But actually these patients, the patients that were coming through, had a positive experience once they arrived there. as a sort of illustration of this sort of coordinated collaborative effort, there were three times a day we had daily huddles. So the various teams working at the various hospitals, together with crisis teams, would kind of come onto a call together, and we would share kind of what the work is. So there was a real picture of who was requiring treatment, what that picture was, and everyone working together to think how best to meet the needs of our patients. And that was happening 3 times a day, so at 9 a.m, at midday, and at 4 o'clock to hand over to the evening teams. So really quite well organised. There was a weekly crisis planning meeting, so a sort of how we're doing, what needs to change, and again with kind of senior management and senior clinical leaders sort of present at that. And what we were able to create was a dedicated mental health ward. Usually there isn't a dedicated mental health ward. We work on the paediatric wards, whereas here we had a very skilled staff group, dedicated and committed to working with patients on this ward, which very much didn't take up the feeling of a psychiatric inpatient unit, but rather a medical ward where they were skilled and well resourced with mental health nurses, with psychiatrists and paediatric nurses to look after mind and body of these young people in crisis. And we also had input from social work within the hospital, and good support from community teams as well. So a really successful collaborative effort and venture, certainly for the first few weeks of it, at least. In terms of sort of some of the difficulties, well, a big one was geography, really. Patients were needing to get from, they might attend at North Middlesex Hospital or the Whittington Hospital. Some patients would go to the A&Es, the emergency departments that they were used to or that they knew about. So they might go to UCLH or Royal Free. And actually the Royal Free emergency department did open up to young people a few weeks into the process. But then they would need to be transferred from there to Great Ormond Street, which is not ideal. In terms of, from a clinical perspective, we were working almost exclusively with crisis work. So I showed you that pie chart of the different aspects of work. Well, actually, almost all we were doing was crisis work. And that was quite grueling for the psychiatrists. It was very challenging for the staff working there. Certainly the paediatric nurses were not used to looking after that group of patients, and it can be very affecting. The young people in a very difficult state, often, for example, struggling with suicidal feelings, and that can get into and is quite different work to what they're used to. So at times people felt very overwhelmed and prone to feeling quite burnt out at times. I've talked and mentioned quite a few times about the mind-body working together, and one of the great benefits of working on a paediatric ward is that we're very much working with mind and body together. Here we had a dedicated ward. That was a great success, but it meant that there was a bit of a sense of the mental health patients separated out. So there was probably less involvement of paediatricians than we might have normally. And it led to something of a mind-body split, which I suppose philosophically, but also practically, was sometimes quite unhelpful. So the risk is that the medical aspects and the physiological aspects of young people's sort of physical well-being may get slightly overlooked, or more overlooked than usual. Another problem we had was that the absence of kind of alternative wards. So and you'll hear about some of them particularly challenging patients that were very difficult, might need restraint, might need medication to help sedate them because they're very, very disturbed. And in those situations, it became, risky and difficult to accept further admissions because the staff were very kind of overwhelmed and busy dealing with that particular patient. And over the course of the few weeks, actually, it became necessary for the Whittington Hospital to open up, for very short term, to open up beds for situations where it wasn't possible or safe to admit a patient from emergency departments at some of the various hospitals. But the absence of an alternative meant sometimes people were waiting in hospital, waiting for it to be possible and safe to transfer and be admitted to Great Ormond Street. And that wasn't ideal. And as I say, later had to sort of change, at least in a short-term way. We found that, yeah, the first few weeks, there was an amazing collaboration, a real sense of kind of, you know, they called it the Blitz spirit, everyone was in it together. And we did find that gradually that eased and waned a little bit, certainly a good few weeks into it. Certain teams probably contributed much less to the cause than others. And gradually the sort of creeping competition crept back in. Certainly my team who had a very heavy workload and at times were needing to take some time off for some annual leave, and a bit disappointed in the level of support that we received from the kind of wider services. And then I think that certainly the fifth C of, I think it was the fifth C of chaos came when as we're seeing actually outside hospitals as well, when we started to remove and move away from the lockdown. So there was a lot of confusion around how long these wards and that model would remain. And gradually, Great Ormond Street were very keen to restart their elective work, which had been put on hold. They were still willing to offer space, but weren't able to maintain the level of clinical input to the services. And unfortunately, the various hospitals, I think, really managing their own uncertainty about what will happen after lockdown, and you know, who might be the victims of the sort of financial pressures that are going to come, started to look after themselves and look after their hospitals, very understandably, but that came at the cost of the collaboration. So in the end, there was a will it close, won't it close, will it close? And there was lots of uncertainty. And in the end, the wards did close at Great Ormond Street in June. And there was really only a few days of preparation for that before it closed and reverted to the current arrangement, which is not back to normal, but is there was a reopening of some of the hospitals. And that was very unsettling, very uncertain what was going to happen, and felt quite different to the initial sort of positive collective venture that we had. Okay. So I'm going to go through some of the themes and the patterns of presentations, and I'll just do this very briefly. I mean, the main, sadly, the main sort of presentations we looked after on the ward were people who either had attempted suicide or were at risk of attempting suicide, and felt so desperate that they had thoughts or wishes to end their life. We also looked after patients with non-suicidal self-harm, so young people often with quite emotionally or physically or traumatic experiences growing up, and who managed distress by self-injury, sometimes very serious self-injury, as you're about to hear. We saw quite a significant deterioration in patients with eating disorders, and I think the particular combination of the kind of contagion fears, but also being stuck at home, and the increased pressure and scrutinization that some of these patients might have felt, really we found that they often found that their eating disorders deteriorated significantly. We had, thankfully few, but a few cases of a psychotic illness, and I'll go through one of those. And then situations where usually linked to kind of the family setting and breakdown in family relationships, but some very challenging and out of control behaviours, sometimes destructive behaviours to property, or running away from home and getting into very difficult and risky situations. And I think these two kind of go hand in hand, but the young people living with families where there's very severe discord, domestic violence and so on, really struggled with their experience. So I'm going to deliver 3 case presentations and just go through these relatively quickly. I'm just mindful of time, so and we need to leave time for discussion. So I'm going to start off with Ruth. Ruth is a 17-year-old who was born with a mild spastic diplegia and who had experienced and suffered with very severe depression and anxiety. She also really struggled with emotional regulation and would resort to very severe self-harm, really shocking self-harm, and had previously attempted to end her life. She also had an attachment disorder, so a disturbance in the sort of the template of kind of relationships, but in particular about experiencing and using a kind of primary caregiver as a safe base, and that's sort of what develops in infancy. But it means that she had a very complicated relationship to kind of help, which might be from family, but it might be from medical services, and reflected this sort of disturbed attachment pattern. She was prone to very sort of black and white thinking, all or nothing thinking, and also experienced some social communication difficulties. So really struggled to convey and communicate her experiences and her feelings. Had previously had an assessment for an autism spectrum disorder, but not felt to suffer with that. She'd had quite an extensive mental health career, as we sometimes call it. So she'd spent a year in an inpatient unit, tier 4 is called an inpatient unit, and finished that in June 2019. And PQ is psychiatric intensive care unit. So for much more risky or troubled patients, sometimes they require a level of nursing input and low stimulus sort of environments, usually secure environments where there's locked doors, and her disturbance had required that sort of setting. She'd left the hospital and she was managed by an assertive outreach team, so a team that could come out to see her at home as well as her seeing them in clinic, and they'd managed since discharge. She'd, since discharge from the hospital, she'd had family therapy and individual therapy and was awaiting an assessment for the adolescent and young adult service at the Tavistock clinic. So first presentation, she presented with very severe self-harm. She'd cut herself really very shockingly and presented to the Whittington extremely distressed. To the emergency department. Her injury required plastic surgery to repair. It was that deep, and it required surgical closure. She was transferred to the hospital, and in the process of doing that, really struggled and became extremely distressed and disturbed, kind of behaviourally shouting and screaming and wanting to leave as well. And in particular, the uncertainties around what was happening. This was very early on, and everyone was getting used to the sort of new arrangement. So, so she found that very difficult. And required medication, some rapid tranquilization, so sedating medication had to be restrained and given intramuscular injections. And was assessed. In order to do that, she wasn't consenting, and so required an assessment under the Mental Health Act. She fortunately settled down fairly quickly after having her plastic surgery, and it was possible to discharge her back to the community. So a week later, she'd found herself previously holding it together because she particularly wanted to continue going to school and engaging in her schoolwork. But really found that increasingly difficult and had opened up her wounds again and become very distressed. On this second presentation, there was lots of conversations between the different hospitals and teams to try and avoid some of the problems that she'd experienced on the first admission that led to her becoming so distressed. And to try and get her across to hospital and treated very quickly. There were lots of concerns. This was delayed because there wasn't RMN, stands for Registered Mental Health Nurse, and she needed one-to-one nursing, but that there was limited availability of that on that particular day. And so things were dragged out and it didn't happen as smoothly as had hoped. Once again, she became very distressed when she arrived at Great Ormond Street Hospital, and there was some delays in surgery, which was experienced by her as really intolerable. And I think she, in particular, often felt that she didn't deserve treatment. She didn't deserve to be, you know, she felt so bad in herself that, and felt that people were wasting resources and their time. And so when delays happened, this kind of reinforced that fear. No one really, rather than interpreting it as the sort of challenges in the services, she experienced it as people making a judgment and feeling that she didn't really deserve it. So it was confirmatory experiences, even though it wasn't intended that way. And once again, she needed to be detained for briefly under a section of the Mental Health Act because of her disturbance. And then to have treatment. And once again, it was possible to discharge her with her family and community team. As part of kind of trying to address this repeating pattern, a hospital passport was developed with her. So things that she found helpful, things that she found really unhelpful, to try and allow her to have a smoother experience of any future presentations. Unfortunately, she didn't last very long at home, and once again came back having harmed herself very severely once again. On this occasion, in light of the previous experiences and with the sort of hospital passport knowledge in hand, actually the surgical team decided that they would actually go to her. In fact, jumped on their scooter, rode over to the Whittington Hospital and offered surgery on site to avoid her having to be transferred from one place to another, which really, from a service point of view, demonstrated a degree of flexibility, which was very helpful. And I think it sort of countered the feeling for the patient that they, you know, that feeling of worthlessness. So it demonstrated that people did care. Unfortunately, it wasn't sufficient to really change her trajectory, and she did require once again assessment under the Mental Health Act. And in the end, having had happened 3 times, it became clear she wasn't coping at home and needed readmission to a psychiatric hospital. There's a little quote here, which from Twitter, which I think captures something of the feeling. So the truth is, this isn't just staying at home and watching Netflix, something that sort of was cited certainly in the early days. And Jamie Lee Finch, who she is, describes its abandonment wounds, its attachment issues, its relationship conflict, its touch starvation, its existential dread, its overwhelm of grief, its lack of purpose, its crippling anxiety, its fear of death. So this sort of captures nicely something of the state of mind for troubled young people who really were struggling with things. Okay, so I'm going to tell you about Raj, another quote: "We don't heal in isolation, but in community." So Raj was a 16-year-old boy who'd been known to Child and Adolescent Mental Health Services for 2 years. He'd had one previous episode about 2 years ago, years before this. Roger'd had a 10-day history of behavioural change, no physical health symptoms, but had become more and more withdrawn and more distressed and unusual in his behaviours. His 10 years previously, he'd experienced anxiety, insomnia, and a terrible guilt, and had started to develop some psychotic symptoms at that time on the basis of these. He didn't have a significant past medical history, lived with his family, from an Asian background, and was busy doing his A-levels. Physical examination was unremarkable, and on mental state examination in the emergency department, he was agitated, felt very persecuted, had persecutory thoughts, and seemed to be responding to unseen stimuli, so hallucinating. He was transferred to Great Ormond Street and agreed to go, although somewhat reluctantly. But whilst there, over the next day, his mental state really deteriorated. He became extremely confused and agitated and aggressive, and seemed to have a sort of fluctuating level of consciousness, sometimes being more settled and communicative, and other times really not. And we became very concerned that he might be experiencing a delirium. So, for example, something like an organic psychosis from an encephalitis or that sort of difficulty. And his confusion and agitation led at times to him trying to run away out of the hospital and requiring restraint, a long period of restraint in the corridor, which was very distressing for him, for his family, and for staff as well. He was detained under, this is, excuse my acronym, so Section 2 of the Mental Health Act. So once again, it was, we needed to use the Mental Health Act to treat against his will. And required general anaesthetic because of his level of disturbance to complete a physical a proper physical investigation workup, blood test, lumbar puncture to exclude an encephalitis, an infective or inflammatory encephalitis, and an MRI scan. He had a slightly abnormal thyroid result, so was hyperthyroid, although it didn't quite account for it. It wasn't sufficiently high to account for his case, but he had an ultrasound and an EEG just to exclude an epilepsy causing his disturbance, and then eventually was discharged to an inpatient unit as well. So in terms of the COVID context for his deterioration, he'd really struggled with being away from school, and working in the home environment had been very, very difficult for him. The family had organised home tuition, and he felt very overwhelmed by having both the work from the tutor and from school. He'd really lost his usual coping strategies going to and from school. Upsettingly, his mum had believed that during the COVID and the lockdown that the clinics were shut, and so she didn't make contact and assumed that no one was operating, which was not the case. And unfortunately, it meant that he probably was left for a couple of weeks before he received the care that he needed, and when he was very unwell by that time. And probably because of the combination of this, much more extreme measures needed to be utilised. I think had he been seen earlier, he might have avoided, could have been treated in the community, but actually, unfortunately, he received medication forcibly, long restraints, needed the Mental Health Act to detain him, and needed an admission for a couple of weeks, which was very, very upsetting for the family. They wanted to avoid that. And finally, I'll talk about Kate. For time, I'm just mindful that we'll need to finish off. So I might just fly through Kate. But a couple of nice quotes, which I'm reluctant. So dysfunctional family is any family with more than one person in it. I think we can all probably understand that one. And a nice Julian Barnes quote, because at some point everyone wants to run away from their life. It's just about the only thing us humans have in common. So this was a very complicated case, which I'm going to kind of really skirt over, but a 13-year-old who'd actually run away from Scotland, from Edinburgh, and travelled to London. A terribly tragic story. She'd experienced very severe abuse within the family home, and had quite extensive contact with mental health services. Actually, the abuse had happened in the family home from a father, and just prior to lockdown, they had planned to move out of that home. But all of those plans had to change when COVID struck, and she found herself, instead of being able to use all the various therapies and supports that she had, stuck back at home in a house that felt very uncomfortable for her. So she'd argued with mum, who she lived with, and run away. She went to a hostel. It was locked. She got very agitated, came to the attention of police, and then became very agitated, probably in a dissociated state, so sort of not really in control of herself, and eventually was brought into the emergency department. She had an autism spectrum diagnosis. She also suffered with obsessive compulsive disorder, has experienced significant trauma, and various other conditions, and was very well known to the child safeguarding and social care team. I'm going to fly through this. I mean, the complexities of looking after this girl was that she really struggled to communicate. She was very oppositional. Once again, we don't actually use the Mental Health Act for most patients, but she did require this because she was initially intent on saying she wanted to end her life. One of the real challenges we had was how to repatriate her, get her back to Scotland, particularly because the mental health law in England is different to the Scottish law. And so they have quite different thresholds for detention and a different approach to things. So it became a real conundrum. So quick quote from John F. Kennedy: Chinese use 2 brush strokes to write the word crisis. One stands for danger, but the other for opportunity. So in a crisis, we need to manage the danger and recognize the opportunities. So how are we doing for time? Right. I'm not going to go through it, so I'll just fly through these. I mean, really, in general, young people, the particular challenges they have, and I think, David, you mentioned one of the questions was around social media and how young people are sort of managing their time in lockdown. It has been very challenging. There's the fear of contagion and getting infected or infecting family. There's managing kind of illness or loss within the family or close friendships, which has really weighed down on some young people. And this is particularly true, especially for adolescents, and the sense of separation from their peers, and the sense of being away from them, particularly at school as well. For some young people, unfortunately, the family is not a safe place, and in lockdown, it really accentuates and brings out some of those stresses. And you know, the loss of school support is massive. So the experience of being away from home in a school setting with peers, with the help from teachers and the school environment, that missing is really challenging for young people. And then, as we've just heard, not being able to access clinical support. So CAMHS clinics doing virtual meetings, which not everybody can sort of manage well, was really challenging. These are some findings from some of the studies that are coming out. I'm not going to go into details with it, and I think I've mentioned already some of the particular conditions, but really to say that there is possible trend towards an increase in child suicide at the moment. Unfortunately, it's not statistically significant, but the numbers thankfully are so low that it's very hard to sort of make a statistically meaningful kind of change. But certainly there does apparently seem to be a possible trend of increase, and younger age, unfortunately, as well, which is quite disturbing. And certainly, particularly for young people who are already finding life difficult or feeling emotional, between 70 and 80% of young people feeling that lockdown has worsened their symptoms. Very challenging for services as well. Professionals having to make the adjustments, the reorganisation, unpredictability, having to do consultations remotely, which is exhausting, as I'm sure those of you are doing it are finding. The collectivism and collaboration sort of giving way to quite fierce competition because of the uncertainties of what's coming up. Very grueling workloads for some. And the curious experience of working from home for those who are, and seeing patients in your own home, not literally, but with your family around, and it just feels that there isn't that separation of kind of work and family life, which certainly can be really, really difficult. And then the benefits, so as John F. Kennedy sort of pointed out, the opportunities for collaboration actually was very exciting and exhilarating initially. It felt like we were in a really exciting project, and we were doing what we were trained to do medicine for, to save lives and to sort of manage, health crises. So it was exciting and exhilarating. Some patients found it very much easier than normal the normal pressures of living in society, so it felt a relief. And children really appreciate that time with the family, being able to do things together. Okay, I've probably said more than enough, so time to open up. I can see a couple of questions here, but perhaps an opportunity for anyone to say what they need to say.
Well, thank you very much. And as you said, we've got quite a few questions that have accumulated. Just to start off with you, as you were talking about the collaboration, I mean, are there lessons about the future collaboration between these hospitals and between the other services in the areas? Are there, is this going to be a kind of breaking the mold, and is it going to be helpful in that context?
So the answer is I really hope so. I think there definitely was a demonstration of a model of working that everyone felt was much more effective, and so a template kind of emerged, and the things that didn't work so well we were able to recognise. So I really hope so. The concern is that whilst there continues to be threats to individual hospitals, it becomes very hard to collaborate, and suddenly that sort of willingness to share and to contribute is kind of reduces quite quickly. And so I think there's an opportunity for the sort of senior leadership to if they're able to provide a level of security and clarity around what opportunities there are, and if there are any cutbacks or sort of changes, so there's a threat to, for example, to one of the paediatric emergency departments, once that's clear, I think there'll be more opportunity to do it. But whilst there remains kind of uncertainty, everyone wants to look after their own terrain, really.
Would you do the same thing in the second wave? What would you do differently, and what would you do the same if second wave is there?
Yeah, it's interesting. So the prediction is that actually the acute hospitals, the sort of narrative is that they believe they would be able to manage a second wave without having to close down the various departments. So the expectation would be that actually they could maintain a paediatric service as well, which initially they didn't. Of course, who knows what the second wave might look like. I think it if there was much greater clarity and better clarity around individual roles, how different teams contributed, then I think it would be, I think it was a real model for excellence. And the question is whether it would be able to, whether that could be kind of harnessed. You know, the experience at Great Ormond Street was that my team did more than the lion's share of dealing with the patients in the hospital, for some good reasons, but actually it was more than was manageable. And so, you know, to work really successfully, it would need to be better resourced.
I mean, there's a question about is this a funding shortage? Is the funding shortage for mental health services really the crisis, or is it the organizational?
Gosh, such a good question and so hard to answer. I think just to sort of sit on the fence a little bit, I think it's both. I think that whilst quite a bit of financial support in the sort of so-called COVID fund was made available, there wasn't a sufficient, so the funding was available, but the resource wasn't, and the specialism wasn't. So whilst the community teams continued to look after their patients as best they could, they weren't available to sort of step up to the emergency and crisis sort of response. So I think, you know, increasing the resource, and it's more people resource than just money, but of course one follows the other. I think that would make a, you know, there does need to be more professionals really, but also better organised professionals and more integrated teams.
This question about video conferencing, were the pluses and minuses of the video conferencing, and how does that go for the future?
Yeah, there are pluses and minuses. So for some patients, it's absolutely transformational. So there's a question about why is hypermobility and Ehlers-Danlos syndrome classified as medically unexplained? My apologies, it's not. Those are not medically unexplained. What's medically unexplained is the syndrome that often or quite commonly that we see, not in everybody with those with that syndrome, but an associated anxiety. And a number of patients with that condition experience chronic fatigue. Now, if you have chronic fatigue, then it becomes very difficult to get to your appointments, particularly if they're in a clinic. And this is where video conferencing really comes into its own. So for people who are very socially inhibited or struggle to get to appointments, it's a godsend. For patients or children whose parents, for whatever reason, can't get them there, it's fantastic. And some people find it easier. They feel less inhibited and more able to share things. But that's only some people. There are a number of young people who find it intolerable, really. They don't feel they're really being paid attention to, and they need that face-to-face contact to feel listened to and understood. And something I really discovered was how much one relies on the kind of, I mean, it sounds so obvious, but how much you rely on looking at people's body language, their mannerisms, and they communicate so much through the way they move as well as what you see. There's some interesting psychological studies around how we, the eyes, gaze, track, and so we do it very differently on on a screen compared to in real life. So we might spend more time looking at the eyes of somebody we're talking to, and then looking around at different aspects of their face, whereas on video conferencing, I think people, well, for a start, you look at yourself because you can see yourself, which is a very unusual thing in communication. You're actually looking at your own image sometimes, but equally not looking at your patient's face in a slightly different way. The other thing I've found is that it feels more exhausting than doing face-to-face consultation. Depends on the consultation, of course, and the patient, but there is a sort of different level of kind of exhaustion, and I think it's because we're having to process kind of social communication cues and information in a slightly different way. which is more effortful. So
there is notably in your list of diagnosis that you came across, there were no, you didn't mention drug-related problems that amongst adolescents, and also related to that, problems of access to medication and or therapy. The one patient, they thought the services were closed, but was that a major issue in actually getting access to either medication or therapists? Two are somewhat related, because drug related maybe.
Yeah, so I'm always surprised at how relatively little we see young people who have, when you say drugs, you mean sort of recreational drugs?
Recreational drugs.
Presumably. So, so we did have some cases, and there were some young people who came in either intoxicated or experiencing kind of the aftermath of it. What we particularly saw is young people who would become very intoxicated, and in their disinhibited state, if they then might have an argument and then might take an overdose, frighteningly. So certainly that was something that we saw not infrequently. But actually, interestingly, I'm always amazed at how little drug and alcohol misuse we see, relatively speaking, compared to how much there is in the population. And yeah, certainly those three cases that I presented, drugs and alcohol, didn't feature. I'd be guessing. I'd need to go back to see. I mean, it's not unusual to see young people who are misusing drugs, but usually it's sort of alongside their mental health difficulties rather than causing it, I would say.
And about the question of access to medication and
so access to medication, it certainly was available for patients who were maintaining their contact with services, and certainly in the hospital I worked at, they actually posted some medications. But I think there is an issue around young people becoming unwell or becoming more unwell and struggling to access their community services. And also the sort of practical issues around, so often because people were working remotely, there would be the kind of very inefficient way of if they did need prescribing, it would go to the GP, and the GP would then need to prescribe electronically, and then patients could pick it up from the pharmacist. But of course, that's not as simple as just, you know, completing the prescription oneself. So it made it certainly less efficient.
It's an interesting, there's also an interesting question of whether, talking about contact with the patients, whether there were any COVID-19 patients and whether you had to wear PPE at all during this, or were you?
Yes, so we had a few patients who were COVID positive. We didn't see, I know the liaison psychiatrist working with adults saw kind of COVID related syndromes and the neuropsychiatric syndromes. But actually, as we know and have seen, children are relatively little affected. There were some cases of, oh goodness, the acronyms just popped out of my mind, but the inflammatory disorder that was seen in children. No, it's gone. But actually they didn't struggle with neuropsychiatric symptoms. So the patients that we saw they weren't sick with it. They tested positive. We did have to wear PPE. So full PPE for them. The PPE we had to wear, that's not quite right. Because it wasn't aerosol generating, so we were able to just wear, we wore masks, gowns and gloves, and that was it. It did have an impact. I think wearing a mask it's a sort of physical barrier, but it's also a bit of a metaphorical barrier, and I think there is a feeling that there's a bit more separation. I'd say, yeah, we had this discussion with colleagues about which is more disruptive to a consultation, wearing a face mask or using a video conferencing. And we didn't come to a consensus. I think for some people, they find it really hard to speak. I would rather use video conferencing and seeing the whole face. Other patients certainly prefer the face-to-face contact, and I think those people feel that just the looking at the body language and people's eyes are enough to convey a feeling of being in, having that sense of being cared for and looked after.
I think we're going to let you have a break in a few minutes, but just the last question was one we actually discussed, was that the question about closing of schools and uses of screens and mobile phones.
Yeah.
Was this is allegedly increased, and
yes.
What's this? Did you find this, and what do you think the impact of this is going to be in the longer term on children, or anything to be done about it?
Yeah. So yes. So we definitely encountered it. I think in family, it became a source of conflict within families, which for young people who were struggling often became the argument point that might tip them into a more risky state. And so feeling that they were being kind of constantly criticised and told off for being on their phones or spending all day on, watching Netflix or whatever. And it became a source of conflict. It's tricky. I'm sure my children would feel the same. Actually, it has become a source of conflict, and it can easily. It's very hard to maintain the positive aspects of kind of interacting with one's family whilst also trying to limit and manage that side. The evidence is quite mixed around the impact of kind of social media and phone and screen use in general. There certainly it's that unclear thing that in and of itself there isn't very clear evidence that it's harmful. It's certainly harmful for some people. So and people who are more vulnerable tend to use screens more, but experience more distress within their kind of screen use, and they might access more upsetting material or distressing material, and they also experience more cyberbullying, for example, or kind of unhelpful kind of interactions. But there are certain groups who certainly it really improves their mental health and their resilience. So, for example, the most obvious is people with autism spectrum disorder, who find that it's so much more straightforward and manageable interacting with people, that they're able to be more sociable rather than less. So in terms, I think it's going to be very interesting to see. There's lots of talk about the post-lockdown surge, which everybody is sort of anticipating. And I think we are concerned that in children and young people, there will be a large surge for the reasons I've sort of outlined. And one of the things that we will see is that people will have been managing the uncertainty and the being stuck and isolated by really maxing out and spending much longer than is healthy on their screens. It affects their physical health because they're less active, but also possibly their mental health. And we will remain to see whether there's going to be much more work in cases around managing kind of the technology addiction, as they sometimes call it, sort of very compulsive and harmful use of technology. The other bit is sleep. So one of the biggest victims, I think Netflix described that their biggest competition is sleep. That's their biggest competitor. And of course, for anyone who watches box sets or gets into that sort of thing, actually there is a real issue around, you know, one show leading to the next, and you don't even have to choose it. It happens automatically. And that really affects sleep. So I think for children and young people who don't have school to wake up for, whose normal routine is out of place, the temptation to watch movies or be on a screen all night and then sleep during the day is there, and then it upsets the sort of melatonin tone and the diurnal sort of biorhythms, and so that's another thing that we will need to sort of anticipate and work with. But at the same time, I think probably screens have allowed many young people to sort of remain sane and connected to their peers over this time. And, you know, here we are. we're meeting as the Medical Association, and we're not having to go without. So I sort of, I suppose I'm reminded about the amazing kind of capacity of humans to adapt and deal with adversity and find a way to connect with each other. So sort of a risk, but also, you know, a helpful thing too, I suppose.
I think we've taken our full whack of your time and energy, and just wanted to thank you very much, not only for what you told us about this field, but also for the way you explained it with sympathy and with the handling both of the patients and of the staff. So thank you very much.
Well, thank you. It was a great pleasure. Honoured to be able to talk to you all.
Thank you.
Okay.